डॉक्टर स्क्रीन नजर आ रही है? डॉक्टर सना? डॉक्टर साउंड क्लियर है? साउंड क्लियर है? डॉक्टर, इज द साउंड क्लियर? डॉक्टर? Okay, students, we will start in 2-3 minutes. Let more people to join in 2-3 minutes, then we will start. Okay, now we are going to start our lecture. This is a very, very important topic, that is the MCH indicator. I am Dr. KHALID SHAFI, Associate Professor, Department of Community Medicine, Dow Medical College, DUHS. MCH indicator means maternal and child health indicators. Before starting the lecture, I just show you a clip from the newspaper. This was published in all the newspapers 2 days back. Students, please read out what is written in that. माँ और बच्चे के लिए support program, health and nutrition conditional cash transfer. This is an announcement from government of Sindh for the Tharparkar and Umarkot districts for the mother and children, that they will be given some sort of the support for the pregnant ladies. And the eligibility to get this thing is that pregnant ladies who have the NADRA CNIC card and who are living in the selected pilot districts which are specified like Tharparkar, Union Council, Singaro, Kejisha, Umarkot, Union Council, Shadi, Pili, Shamadan Shah. The important characteristics of this program is that the females who are pregnant and will come for the antenatal visit, they will be given some cash money, and that cash money is described as that on every antenatal checkup, they will be given 1,000 rupees per checkup. In case of delivery in the hospital, they will be given 4,000 rupees. And for the child to get the birth certificate, they will be given 2,000 rupees. And after the birth, when the mother will come for checking the baby, she will be given 1,000 rupees every time. And when the mother will come for the vaccination or the growth monitoring, she will also be given 1,000 rupees for each time she visits the health facility. Some of you will not understand the importance of this, what is given in this sport program. We will be discussing this while we will be conducting the lecture, because this is very much concerned and associated what we are going to discuss in today's lecture. Okay, Ji, the learning objectives of today's lecture is that at the end of session, the student will learn what is health indicator, why health indicators are important or used, and then we will be knowing what are the maternal and child indicators. And we will also look, similarly, we will also what by which we can prevent that. So let's first define what is health indicator. Health indicator is a quantifiable characteristic of a population, and the researcher used this as a supporting evidence because it is describing different parameters regarding the health of a population: life expectancy at birth, infant mortality rate, under 5 mortality rate, maternal mortality ratio, growth pattern, percentage of children immunized. A lot of health indicators are there, and we will be discussing some of them in today's lecture. So health indicators are important because why they're important? They help us in highlighting the problems. They help us in identifying the trends. They help us in priority setting, and they help us in the policy formulation, and also they help us in the evaluation and monitoring of the progress. What I showed you in the first slide, a clip from the newspaper, all this priority and this money and this project was made because of the high number of the maternal death and the infant death in those areas which are indicated in that. And to solve this problem, to give as a help, as an incentive, some money will be given for the people, for the pregnant ladies and this money deal and eating things which are helpful, which will help to increase the weight of their baby. Secondly, they will use this money for the transport coming to the health center. So let's discuss MCH status is assessed. How it is assessed by 3 sort of the indicators. One is the mortality indicators, second is the morbidity indicators, and the third is the growth and development. Mortality indicators mean the indicators which tell us about the death in that or a special group of the people. Morbidity indicators are that indicator which tell us about the disease pattern in that area, and the growth and development tell us about how the child is growing. So first of all, we just look at a list of the important indicators. They are the maternal mortality ratio. We'll discuss this in detail, is taking care of the children. And then comes the neonatal mortality rate, then the post-neonatal mortality rate, perinatal mortality rate, then 1 to 4 years mortality rate, then under 5 survival rate. This is few of the indicators which are used, but today's lecture will discuss only few of them, obviously because of the time constraint. Maternal death, the most important part of the today's discussion. Saving mother's life is a priority of the WHO. In fact, it is the priority of everybody. It's a priority of the nation. It's a priority of the family. But about 830 women die each day due to complications in the pregnancy and childbirth. It means for every hour, more than 20 women leave this world while trying to give birth to a baby. 830 women each day is quite a high number. And this 830 is despite that there is 44% reduction in the maternal deaths between the 1990 and the 2015. Means during a period of 25 years, the reduction is 44%, but still it is very high. If we go to the number, in the 1990, 532,000 were dying, female were dying because of the pregnancy and related causes. In 2015, around 3 lakh females are dying because of the causes related to the pregnancy. The aim is that no woman should die in pregnancy and the child. That is the ultimate aim. Not it is 230, 330, 430. It should be 0. That is the aim. That is not possible very easily. It should be done, but it's not an easy task. Mortality indicators, while we were discussing about the mortality indicators, mortality means death. So the indicator tells us how many deaths are there in the population. The numerator, we use the deaths of the population about which we are talking. For example, if we are talking about the maternal mortality, then the females dying during the pregnancy, will define in detail in the next slide, will be in the numerator, while the denominator, the female population of the childbearing age are giving birth to the children, will be in the denominator. And for the ease of calculation, we usually multiply by 1,000 or 100 or 10,000, whatever the figure is. Okay, now come to the most important indicator of the MCH is the maternal mortality ratio. Maternal mortality ratio means maternal death. Let's define what is maternal death. That is the numerator in our this ratio. Maternal death is defined as a death of a woman while pregnant or within 42 days of the termination of pregnancy from any cause related to or aggravated by the pregnancy or its management, but not from the accidental or the incidental causes. It means from the start of the conception, whole pregnancy, then the delivery or abortion, whatever, and 42 days after that is included in the period in which if the death occurs, it will be called maternal death. And it should be from the cause related to pregnancy or aggravated by the pregnancy. For example, if the female have the congenital heart disease or the heart disease, some wall problem, and it is aggravated due to pregnancy, we know very well about the pregnancy that is a physiological process, but there are a lot of changes in the body. So if the cause is aggravated even and the cause pre-exists, it will be included in the maternal death. But accidental and incidental causes will not be included while we calculate the maternal death. So the maternal mortality ratio is number of deaths of mothers due to childbearing and prepuce causes that we have defined from the conception till 42 days after the delivery or the termination of pregnancy, divided by total number of live births recorded at the same place during the same year, and multiplied by, usually it is multiplied by the 10,000, not 1,000, it's 10,000. So the maternal mortality ratio is the number of deaths of the mothers due to the childbearing and prepuce causes and divided by total number of live births in that area during the same year. Note one thing, usually the indicators, numerator and denominators are the same, and we call it rate, but this is not rate. This is maternal mortality ratio. Look at the terminology, because if the numerators and the denominators are not the same, then this is not called the rate. So what we are talking about this is the maternal mortality ratio, because in the numerator we are including deaths of the mothers, while in the denominator we are taking live births of the children. Events are different. So it is called the maternal mortality ratio, but this ratio is used as indicator. There is another indicator, it is called the maternal mortality rate. Usually it is not used, but if we define that, it is the number of maternal deaths in a given period per population divided by the women of the reproductive age. It's a different from that, because women who are at risk. But that does not truly tell us about the situation. This maternal mortality ratio precisely tells how many events occur and how many deaths occurs. Events is the birth and numerator is the death. So the maternal mortality ratio, we are clear about that. If we classify the maternal deaths, there are two types of reasons. If we can classify the reason into two, one is a direct obstetric deaths, which are directly related with the delivery process. So the deaths resulting from the obstetric complications of the pregnancy. Second is indirect obstetric deaths, means deaths resulting from the previous existing disease or the disease that developed during the pregnancy and aggravated by the physiological effects of pregnancy. We'll go in bit detail of those. Both are included in the maternal deaths, but we can classify the causes into direct and indirect. Look at this. Direct obstetric causes. Toxemias of the pregnancy, purely related to pregnancy. Eclampsia, pre-eclampsia, jaundice in the pregnancy, etc. Hemorrhage, bleeding during the birth process. Antepartum hemorrhage, postpartum hemorrhage. Infection, puerperal sepsis, tetanus, other things. Obstetric labor, when the labor do not progress, the problem will occur to the baby and the mother. Abortion and the complication of abortion. These are all directly obstetric causes. The non-obstetric causes, some of them are anemia. If the female is already anemic, then something occurs in the pregnancy and she cannot tolerate that. Associated diseases, for example, cardiac renal infections. If she has already some cardiac problem, she is compromised, she is already in the renal failure, she is already suffering from the infection, or she suffers from the malaria, dengue, COVID, something else. And malignancy, if she suffers from the malignancy during the pregnancy or before that, then accidents, different forms of the accidents may occur, resulting in the death of the female. So the causes of maternal mortality broadly classified into direct causes, that is the obstetric causes, and the indirect causes, which are the non-obstetric causes. These are the few of them, this is not all of them. Besides this, direct causes, there are social factors of maternal mortality. There is an verses or poetry, हादसा अचानक नहीं होता, वक्त करता है परवरिश बरस. शायद मैं I have taken words here and there. The problems may occur immediately, or there are something which is cooking before that and ultimately results in the bad news. So the social factors of maternal mortality which contribute towards the maternal well-being and mortality, both sides, are, we will discuss. Age at the childbirth. If the female is married early, the children are born very early or very late, it is very risky for the female. Then parity. First child, risk is high. If she is grand multipara, 5, 6 children, 5, 6, 7, 8 pregnancy, the risk will be high. Shortage of health manpower. If there are complications like bleeding, hemorrhage, obstetric labor, if you have the capacity to handle that, you can save the baby and the mother most likely. But shortage, the problem will occur. Too close pregnancies. If the pregnancy is less than 2 years gap, the risk to the mother will increase. Delivery by untrained midwives. If adequate skilled person is not present at the delivery, it will be harmful to the baby and mother. We are poor environmental sanitation. The environment where the female is living, the environment where the female is being delivered, both causes contributes towards the bad events, infections, malnutrition, lot of things. Poor communication. If the female is not informed, aware, concerned about the problems, it contributes to the bad events. Social customs like not visiting the doctor, taking too late to the hospital, etc., giving less diet to the female, unhuman attitude towards the females. These are the social customs. It contributes towards the maternal unwellness and ultimately sometimes the maternal mortality. Parity we have discussed, too close pregnancy we have discussed, family size, too large family, less attention to the pregnant lady, malnutrition, hunger, thirst, poor diet, inadequate diet, low quality diet, poverty. These are all interrelated. Unfortunately, when there is poverty, there is large family size. There are too close pregnancies, illiteracy, ignorance, lack of maternity services. These are all disasters which contributes towards the maternal mortality. Now you can understand the newspaper clip, the package which is given to the females of a remote area of Pakistan where economy is low, the illiteracy is high, ignorance is too much, lack of maternity services. The incentive is given to the females. Social customs are that not to take the medical care properly. The females are encouraged to come to the health facility, get their proper checkup, antenatal care. They're given some money to buy the food, to buy the wheat, rice, meat, eggs, etc., to eat them and increase their weight adequately as is required during the pregnancy. That will help in the health of the mother, correction of anemia, and the weight of the fetus, and ultimately decrease in the reduction of the birth of the low birth weight babies. Every day we hear on the newspapers, on the TV radio, Tharparkar mein ek nanni kali murja gayi. This is to prevent that. We should listen and read this lecture, understand this lecture of the MCH indicator in practical situation. The practical situation is there in Pakistan and the solutions are being implemented, tried to be implemented. So the maternal mortality prevention, what is required? Early registration of the pregnancy. The female should come to the health facility as early as possible because she will be assessed, she will be given the right advice. Identification of high risk groups. High risk group we have discussed, close pregnancies, parity, early marriage, age at the conception, etc., etc. So high risk female should be identified. They will be identified only if they come to the hospital, to the health facility. There should be at least 3 antenatal visits. We have discussed in the previous lecture, in the maternal care lecture, that there should be monthly visit in the first 7 months, and then should be every 15 days. Then after 40 weeks, every day, and 42 days, the female should be admitted in the hospital pregnancy. But anyhow, in the worst situation, there should be at least 3 antenatal visits. Dietary supplementation. Pregnancy is a special situation, exaggerated physiological process. Mother has to take diet for herself. For the baby, there should be a 10 to 12 kg weight. How the weight gain will be there? Placenta has to grow, baby has to grow. She needs extra diet. Extra diet. Prevention of infection. She should be living, mother should be living in the clean environment. Mosquito-free, fly-free environment, clean water, pure air, not contaminated eating things, etc. Prevention of complications. If we want to prevent the high maternal mortality in our country, we have to prevent the complication. We have discussed the prevention of complications means good antenatal care, good natal care, good postnatal care, prevention of infection, trained birth staff, etc. And obviously, along with the treatment of the medical conditions, the female is anemic, she develops jaundice, she has high blood pressure, she develops preeclampsia, whatsoever it is, if you have cardiac disease, all the things are manageable if we manage them with them. Maternal mortality prevention, sometime in the areas where the malaria is high, anti-malarial prophylaxis in the high transmission area is very necessary, because if a pregnant female suffers from the infection, whatever it is, malaria, COVID, this dengue, etc., the very much chances of abortion are damage to the fetus. So anti-malarial prophylaxis can be given in the high transmission area, tetanus toxoid vaccination. We have discussed in the previous lecture of the maternal care, and we will be discussing again on Saturday in the lecture of the vaccination, that every female of the child-bearing age should be given 5 doses of tetanus toxoid. We'll discuss in detail in the next lecture. Clean delivery practices, very important to prevent the infection like tetanus or the other type of infection. The delivery room, the delivery place should be clean. Sitting in Karachi at the Dow Medical College, Oja Hospital, Civil Hospital, it looks not very difficult. But at the Tharparkar and the other area, it is not easy that the female should give birth to the baby in the clean delivery practice place. Delivery should be by trained midwives. It should be by the trained doctor, midwife, lady health visitor, even the birth, they are for the high risk growth. In fact, at the health facility, the delivery related reason, there should be adequate gap. Family size should be of some reasonable size according to the financial situation and age of the mother. At least there should be a gap of 2 years between the 2 pregnancies. At least this is not. That family planning is an essential part for the survival of the female of this age. Then identification of the maternal death and searching the cause. This is also important. We should realize that knowledge and treatment and management is not enough. Research is an integral part of the medical care. If you don't do research, you're not able to give good care to your patients. Socioeconomic development, very important aspect. People don't have money to buy food, to travel for the transport fares, etc. They avoid going to the hospital. They keep on producing children at home, and children keep dying and the mothers keep dying. This, if there is socioeconomic development, their literacy rate will increase, the awareness will increase, they will like to go, because we have discussed that in the rich group of the people, the maternal mortality rate is quite low. So the initiatives to reduce the maternal mortality, a lot of initiatives have discussed that from the 1990 to 2050 over a period of 25 years, there is 43% reduction in the maternal mortality rate. So Safe Motherhood Initiative was launched in 1987, and it drew attention to the multifaceted nature of the problem. Human rights, empowerment of women, education, socioeconomic development, and the improvement of health system. These were the part of the Safe Motherhood, and it was practiced over the world, where some places good, some places not very good. But the benefits we have shown, we have seen that there were 43% reduction. It was because of this Safe Motherhood Initiative guidelines. So now, summarizing the maternal mortality, its causes, etc., we now come to the mortality in the infancy and the childhood. In the childhood, infancy, there are multiple reasons. We can broadly divide the causes of the mortality in the children in under 1 year, 1 month of age, that is called the neonatal mortality, and under 1 year of age, that is called the infant mortality. And if we further divide infant mortality in the neonatal, and from 1 month till the 1 year of age is a postnatal mortality, then very important thing is under 5 mortality. So we will discuss it one by one. Let's have definition of certain terms. While discussing the mortality in infancy and childhood, we need to define certain terms. Fetal death. What is fetal death? Fetal death means it's a death prior to complete expulsion or extraction from its mother of a product of conception, irrespective of the duration of the pregnancy. Let's make it clear the first 3 lines. It means if the product of conception, they're using the word the product of conception because it may be 2 weeks, 4 weeks, 6 weeks, 10 weeks, whatever. If the death prior to delivery occurs, it will be called the fetal death. The death prior to delivery inside the uterus is indicated by the fact that after such separation of the fetus does not breathe or show any evidence of the life, such as beating of the heart rate, pulsation of the umbilical cord, or the definite movements of the voluntary muscle. It means if a baby is delivered, whatever the age, and at birth, baby do not have any heart rate, any activity, any sign of breathing, any movement of the body, so it will be called fetal death. The fetus may be 6 weeks old, 10 weeks, 14 weeks, whatever it is, it will be called the fetal death. Nowadays, fetal death can be determined by the other methods. For example, CTG, sonography, fetal hearts can be listened to the fetoscope, and by the ultrasound also the fetal death can be determined even prior to delivery. So, now coming to the definition. First definition is a neonatal mortality rate. Neonate is a baby under 28 days of age or the 4 weeks of age. So, total number of deaths of the children in the first 28 days means a neonatal death over a year divided by total number of live births during the same period or same place. For example, Karachi, how many babies expired before 1 month of age will be in the numerator, and the denominator will be the total number of the deliveries or births which occurred in the Karachi. For example, in a year, multiplied by 1000, it is called the neonatal mortality rate. Then comes the infant mortality rate. This is the most important indicator in the child health. Infant is the child under 1 year of age. So the number of deaths of children less than 1 year of age in a year divided by number of live births in the same year and multiplied by 1000. It is called infant mortality rate. Then comes, now we have discussed neonatal mortality rate. We have discussed definition of parental mortality rate. We'll go to the cause and prevention subsequently after defining these certain terms. Perinatal mortality rate. The terms used are total birth. Total birth is called live births and stillbirth. In the previous 2 indicators, look at this, neonatal and infant. We have used the denominator only the number of live births in the same year. But by calculating the perinatal mortality, peri means after 28 weeks and first 7 days of birth is a perinatal period. So the total births, if the term used will be the live birth plus the stillbirth, and the stillbirth is the death of fetus after 28 weeks of pregnancy. So the perinatal mortality rate is calculated by the sum of the total number of deaths of fetus after 28 weeks of pregnancy and death of the children under 1 week of age at a place during 1 year. Means number of the babies who born dead or who were found dead in the fetus after 28 weeks of gestation. Before 28 weeks, they will not be included in this. So after 28 weeks plus the babies who expired within 7 days of birth, this both are, sum of both is taken, divided by total number of births recorded at the same place during the year. multiplied by 1000. It is the perinatal mortality rate. Actually, neonatal mortality rate, infant mortality rate tell us about the status of the health care facilities to the children, while the perinatal mortality rate tells us about the health status facilities during the pregnancy, obstetric facilities, plus immediately at birth. Because if the child is expired within 7 days, it is very much related to the maternal causes. So what are the causes of perinatal mortality causes? Let's discuss for this. Means perinatal mortality means death of the fetus after 28 weeks plus the deaths of the children under 1 week. This is the sum of both is called the perinatal mortality. So the causes are obviously divided in three. Number one, the antenatal causes. Placental insufficiency. If there is not enough supply from the placenta to the baby, or itself placenta is not adequately formed, unable to nourish the baby, what will happen to the baby? Low birth weight, failure to grow, and may expire, because the sole source of the nutrition, blood supply, oxygen, etc. is the placenta to the fetus. Placental insufficiency. Number two, pregnancy associated with the diseases like the preeclampsia, toxemia, high blood pressure, proteinuria, edema. Other also diseases are there, jaundice, hepatitis E infection, etc. RH incompatibility. RH incompatibility in the subsequent pregnancies, not in the first, second, third, fourth, may cause the death of the fetus. Anemia. Anemia can be a major contributory factor. The female may have some bleeding, hemorrhage, etc. If she has good hemoglobin, she will withstand that, tolerate that, survive from that. But if she is already anemic and if there is bleeding from any reason, chances of the survival of the baby and the mother will be compromised. Perinatal mortality causes. Second is the internatal causes. Internatal means during the delivery process. Birth injuries, asphyxia, obstetric complications. Birth injuries means the baby is delivered and it required, for example, there is CPD, cephalopelvic disproportion, and you try to deliver the baby. What will happen? Baby will have broken bones, clavicle, humerus, femur, etc. Or other traumas will be there. Asphyxia. If the baby do not breathe at birth, we have defined this asphyxia. Our first lecture of the reproductive health, community medicine, infant care. What was asphyxia? Apgar score. On the base of the Apgar score, we define the asphyxia. It is an old method. We'll be learning about it in the pediatrics. So, birth injuries and asphyxia and obstetric complications are there. It can cause the death of the baby within 7 days. Postnatal causes, that is after the delivery. Premature baby, if the baby is born 24 weeks, 26 weeks, 28 weeks, baby will have complications like respiratory distress syndrome, hyaline membrane disease, prematurity, jaundice, infection, necrotizing enterocolitis. Lot of things are associated with prematurity. Then, if a baby is even premature with the normal weight, baby may have respiratory distress syndrome. There are many reasons of respiratory distress in the newborn, starting from the hyaline membrane disease, then the meconium aspiration, then the transient tachypnea, congenital pneumonia, infection, lot of things. Then the infections of the respiratory and the alimentary tract. Congenital anomalies. There are some congenital anomalies which make life difficult for the baby, and some babies do not tolerate that, so they expire. Some congenital heart diseases are there, some other anomalies are there, malnutritions are there, cleft palate, cleft lip palate. Some are manageable, but all are either not manageable or the facilities to manage them are not present in our setup or most of the places in the third world or developing world. So we have discussed the causes of the perinatal mortality, which were antenatal causes, internatal causes, and postnatal causes. So let's have a break of 1 minute. Now, medical causes of infant mortality rate. We have defined infant mortality rate, number of deaths of the children under 1 year of age, divided by total number of live births in the same area, same period. So for Karachi, if we calculate the infant mortality rate, we will include all the children born in the Karachi from 1st July to the 30th June of a year, from 2019 to 2020, and total number of the children who died under 1 year of age in the same area. The medical causes of infant mortality are neonatal mortality will be included in the postnatal mortality. Neonatal mortality, low birth weight babies. If a baby is born, then what should be the weight of baby at that time? We have defined low birth weight in our first lecture of the infant care. You should be knowing by this. Huh? Low birth weight is on the top. They contribute to that death. They are the first to die if their weight is anomalies. We have discussed this in the previous slide. Hemolytic disease of newborn, that is the RS incompatibility, are the other hemolytic disease, ABO incompatibility will be there. Conditions of placenta and the cord. Placenta is insufficient, insufficiency of the placenta. If instead of 3 vessels, there are 2 vessels in the cord and the other things, it can cause some damage to the baby, problem to the baby. Diarrheal diseases, acute respiratory tract infection, and unfortunately in this era, tetanus is still a cause of infant mortality in the postnatal. Diarrheal diseases, on the top is the respiratory infection, then diarrheal disease. Still in Pakistan, children die because of the respiratory infection, pneumonia, diarrhea, loose motion vomiting. Then there are communicable diseases like malaria, other things are there, other infections are there. Malnutrition, if the baby is born with a low birth weight, not giving the breastfeeding properly, not giving the immunization, not taking care of the properly, the baby will become malnourished. Congenital anomalies, children also suffer. Then let's discuss what are the factors affecting infant mortality. Biological factors. Birth weight, very important indicator. Mostly it decides the survival chances of the baby. Age of mother. If the mother is too young or too old, the baby have some problem at birth, may have. Birth order. Birth spacing. 2 close pregnancies, multiple births, large family size, high fertility, it all in a way is same thing. Large family, out of resources, 2 early deliveries of the baby. All these are the biological factors which affect the survival chances of a baby. Then economic factors. Obviously, if there is enough money, enough food, enough facilities, enough medical care, access to the medical care, transport, money to buy the medicines, money to buy the eggs, meat, fruits, health will be better. Education will be better. Economy is a very important factor in all the health indicators. Then, beside economy, cultural and social factors. Only money is not the matter. It's the wisdom, it's the knowledge, it's the skill, it's the counseling, it's the way the person also matters. So the cultural and social factors, breastfeeding. We will be seeing in the last slides what is the status of breastfeeding in Pakistan. Customs. The children are given makhan, shahad, etc., instead of breastfeeding. Early marriage, quality of mothering, how mother is taking care of the baby. Maternal education, mother is educated, she will take better care of the baby. Quality of the healthcare, born at the Khan University Hospital, Civil Hospital, South City Hospital, and being born at the Tharparkar. There's a difference. Broken families, husband and wife, saas susar nand, what to say, lot of problems are there, and it affects the babies. The ultimate victim of all such things are the females and the children. What happens around us ultimately suffer. Who are the weak, who are the weakest? Children are the weakest, the females are the weakest. Illegitimate babies. Even in the presence of the parents, baby a problem, and if there is no one owns the baby, what will happen to the baby? One can imagine. Untrained midwives. A person who does not know the work, if he start working, what will happen to that? Same thing happens to the poor mother and the baby. Bad environmental sanitation. If the environment is not clean, mother will have malaria, typhoid, etc. Baby will have all these things. These are all the factors which directly, indirectly affect the survival of the child and contribute towards the high infant mortality rate. The biological determinants we have discussed: birth weight, risk in the low birth weight is high; age of mother, risk in the too young, too old mother; birth, risk in the firstborn and after 5-born increases; family size, risk is high in the large families due to the improper care and the infection; economic factor we have discussed, and the statistics show that the infant mortality rate is low in the rich families, owing to better quality of health care and availability of the social factors. Illiteracy, poor knowledge of the child care, and the sex of the child is an important factor. Female babies are given less attention. Whatever we say, with the education, awareness, situation is becoming better and better, but still it is not better in most of the places. When a female baby is born, first of all, the mother is given blame. How she delivered the female baby, she should deliver a male baby. And then the female and mother and the baby both are treated in an improper way. If a female baby is sick, the father will not take her to the hospital. If the male is sick, he will run to the hospital. Broken families, we have discussed this. That is also a tragedy. If we want our females to be happy, if we want our children not to die, we should work on all these contributory causes. Lack of trained birth attendants, we have discussed. Poor environmental situation, we have discussed. Lack of water and food sanitation, overcrowding, small house, too many people living in the same room or the same place. So, if we summarize all this, there is multiple causation web model for the infant mortality. Students, you must be remembering while we were discussing the causation model of different diseases. There was a triangle, then there was wheel model, and then there was a web model. Web model means multiple complex things are there which affect on the outcome of the disease. So like is the infant mortality, it is not the sole reason. Maybe sometimes the sole reason the child may have pneumonia, but why the child has pneumonia? Because child was born by a mother whose age was either low, either high, or she gave birth to the too small interval of the pregnancy. The baby fetus was not nourished well because of the poor family and the lack of education. The child will suffer from the pneumonia and the diarrhea and ultimately dies from this. So, explained by the web model, not single model. What are the different factors? Poor of care. We have discussed this. Quality of health care, poorly trained TBAs, non-complying religious belief. Babies are given by the God. You do not have any means to intervene. Gender bias. We have discussed this in detail just now. Infections of the mother and baby due to the poor domestic condition, poor environment, and there are miscellaneous causes like the age parity, repeated pregnancy sector, and economic and the social problems. All this make a web position for the high infant mortality rate. At-risk infants, we have discussed all about this. We are again repeating that so we can understand and learn that and remember that. Birth weight less than 2.5 kg. Very important for the survival chance of baby. Twins baby, spacing less than 2 years between the two deliveries. Birth order number 5 or more. History of death of more than 2 siblings during the past 2 years. Artificial feeding means not giving the breastfeed. Weight below the 70% accepted weight. If it is less than the standard weight, it's called the malnourished child. And the chances of dying a malnourished child with the weight during 3 successive months, if the baby is born with a 2 kg weight and not gaining weight, aren't losing weight, that means that the baby is at risk of dying. Now, what is maternal and child health services? Baby should be delivered to the preventive programs. Gobi FF is a very famous intervention once it was done. G means growth monitoring, O means ORS, B means breastfeeding, and I means immunization. Triple F means female education, family planning, and food. Food supply. The baby will be born with a good weight. If baby is beginning breastfeeding, properly immunized, then the chances of death and pneumonia will be less. Baby will be, chances of survival will be increased. Growth monitoring. It is a low-cost care. Growth chart we discussed that every time a child comes to health facility, his weight should be done and plot on the growth chart. So the doctor and the mother both will be knowing whether a child is growing or not. And if not, then what interventions are required. ORS and ORT, child may have diarrhea. If you give the ORS, hydrate the child, you can prevent so many complications and deaths even. Breastfeeding and weaning,
जा रही है आवाज? अच्छा जी, okay जी. We were discussing about the measure to reduce the infant mortality. We were on this slide. So the measure to reduce infant mortality, we have discussed most of them. What were left? Improvement in the living standards, better control of communicable diseases, obstetric and health services, and advances in the food supplementation. We have discussed this already in the different slides. Now, there should be an organizational structure of the MCH services. That is the maternal child health services, means there should be one doctor for greater than 20,000 population and lady health visitor for the 3,000 to 5,000 population, and one trained midwife for 100 births. And there should be trained one birth attendant for one village, and the children should be fully immunized, and utilization of the MCH services assessed. This were the structure. Now, how it is assessed? Percentage of children fully immunized, antenatal care at the health facility, percentage of TT coverage, that is test and talk ties, percentage of birth attendees by the SBS, and percentage of institutional deliveries. So now we have discussed in detail about the MCH indicators. Now, in the last 2-3 slides, we'll see what is the situation in Pakistan. Neonatal mortality rate. These are the slides taken from the national data. Neonatal mortality rate, look at the first graph. In 1990, it was 49. After a struggle of 40 years, it is 42. Still in Pakistan, if the 1,000 babies are born, 42 of them die within 1 month. Infant mortality rate. Number of children dying under 1 year of age. In 1990, 24 years back, it was 86. It is now 62. Highest infant mortality in the world is 62 children die. And under 5 mortality is 74. It is in decrease from the 112 in 1990. It is 74. Enormous amount of the money is being spent in Pakistan to improve these indicators. But unfortunately, we have failed to achieve the targets. Look at this indicator. In the civilized world, only 5-6 children per 1,000 die, and that due to congenital anomalies, etc. But in our children, very, very high infant under 5 and neonatal mortality rate. This is very unfortunate, a challenge. And we know the reasons very well. Look at this slide. Breastfeeding. Exclusive breastfeeding, the main important survival, one of the most important survival chance of the babies are breastfeeding, 48.4% exclusive breastfeeding rate. It should be 100%. It should be 90%. But in Pakistan, it is just 48.4. It means 50% of the mother do not breastfeed babies as is advised. They start top feeding, pneumonia occur, diarrhea occur, and the child dies. Then comes the vaccination. Pneumonia, diarrhea, lot of vaccinations are there. Against 10 diseases, vaccines are available. We discuss on the set in detail. But look at this slide. Only 66% children receive basic immunization. It means 34% children do not get the adequate immunization against the measles, polio, typhoid, rotavirus. The vaccines are there. Children are there. But their parents, their healthcare worker, whatever, say who is responsible, do not vaccinate them. And what happens? Result in the high infant and under 5 child mortality. This is a state of affair here. And we have discussed detail all the things. So by this, I conclude my session. Inshallah, on Saturday, we will discuss very important topic related to this. It will be vaccination. Thank you, students. Allah Hafiz.